I welcome you to this lecture on wound healing. So here we are going to talk about the four phases. I have some interesting analogy and hook for you. Without further delay, let's get started. Phase 1 is hemostasis. Have you ever wondered what happens in the first few seconds after a cut? Did you think your blood's only job is to flow? At the wound site, the blood becomes a rapid fire repair crew. Let's see how it happens. The immediate response after a cut is vasoconstriction, so that it reduces the bleeding by narrowing the vessel. And there is a clot formation. The clot can be formed by the platelets and then the coagulation cascade occurs. So, endothelin is a potent vasoconstrictor in pulmonary hypertension. The endothelin can also be present as a vasoconstrictor at wound sites. This is asked in one of the questions. Phase 2, there is an inflammatory response. The first 3 days, initially the neutrophils will predominate. Later, the macrophages will take over after about 2 to 3 days. So what will be the cardinal signs when the neutrophils and the macrophages enter the site and it will try to repair? We all know when we have sustained a wound, there is redness, there is heat, there is swelling, and there is pain. So white blood cell extravasation establishes the inflammatory microenvironment essential for subsequent healing phases. The third phase is the proliferative phase. Before I go deep into it, I want you to ponder, why does a wound often look pink and bumpy while it's healing? Even on a dark skin, if you had noticed, it will be pink and bumpy. That is nothing but it is the granulation tissue. It is the body's living scaffold which is packed with new blood vessels and collagen which are working to close the gap. What is really a granulation tissue mean? It is called granulation because under the microscope and even to the naked eye it looks grainy. Why should it look grainy? Because of the many tiny new capillaries. It's soft, moist and pink or red in appearance. It is mainly the blood vessels which gives it the granulation appearance. The pink, highly vascular rich tissue is the type 3 collagen that forms the foundation. The new blood vessel formation provides nutrients and oxygen to the healing tissue. Surface reepithelialization closes the wounded defect. Following it, myofibroblasts mediated contraction reduces the wound size. This takes a few days to weeks depending on the wound size and complexity. I want you to notice that the type 3 collagen forms the foundation. What about phase 4? Phase 4, remodeling and maturation happens. Here, the type 3 collagen is replaced by type 1. Type 3 is pink and weaker while type 1 is white and stronger. The transforming growth factor beta is important for increasing the fibroblast migration and proliferation, increased synthesis of collagen and fibronectin, and decreased degradation of extracellular matrix proteins. Because the extracellular matrix, if it goes degraded by matrix metalloproteinases, the scar hasn't been fully fixed or the wound hasn't been fully healed. So we don't want increased degradation. We want decreased degradation of the extracellular matrix by matrix metalloproteinases. The myofibroblasts and matrix metalloproteinases are the answers. If they ask you about the scar contraction is caused by myofibroblast and matrix metalloproteinase. I have a separate video about myofibroblast which is listed in the pathology playlist where I have mentioned about an analogy and in detail it goes. You can listen it if you want. And what is the cell that initiates the fibrosis? That is the macrophages. So after the type 3 collagen is replaced by type 1, the collagen becomes much more stronger. The scar will regain 80% of its original tensile strength. What do they mean by it? Tensile strength is the ability to not break apart when pulled from both the ends. So that is tensile strength. The skin has that tensile strength. The scar which is formed will only have 80% of the original tensile strength. So matrix remodeling is weeks to months of continuous reorganization will happen, such that it forms the area forms almost similar to the original skin. So finally, and a leukocyte extravasation, I will tell you about this 4-step process where initially there will be margination and rolling. What is margination? The leukocytes, here you see the neutrophils are undergoing margination towards the endothelial cells. This is the cell vessel wall and it undergoes rolling. It rolls on the endothelial cells. This is by the E-selectin, P-selectin and L-selectins on the endothelial cells. So these are selectins are present on the endothelial cells and it binds to the WBCs. The tight binding is by the LFA1 CD18 integrin which is present on the neutrophils such that it binds to the endothelial cells. So when that is absent, it gives rise to leukocyte adhesion deficiency. I have a video on leukocyte adhesion which is in my immunology playlist. The step 3 is diapedesis, where the transmigration of the cell through the endothelial cells, as you see here, through the endothelial cells, and this is the site of infection. This is the tissue. That is diapedesis happens. Following this, it migrates towards the injured site. How? There are some chemotaxis like leukotriene B4, interleukin 8, C5a, kallikrein, platelet activating factor, and bacterial products in the tissue which causes the chemotaxis. That is, attracts the neutrophils over here. So this is the leukocyte extravasation or a 4-step process which happens here. With this, we have come to the end of our presentation. I hope this has been clear for you. So I have a good news. I'm starting my mentoring lessons for medical graduates and USMLE aspirants. If you like my videos and if you want to get mentored by me, send me a message in the comments. All the best for whatever exam you are appearing. Have a good day.